Thank you very much. Good afternoon to this great meeting. And again, the great congratulations to Wolfram and team gathering such a big group late in the day. The room is full. So I'm interventional cardiologist, but this relates to structural intervention, so I think I'm on safe ground. So as you know, manipulating the devices or catheters in the body always release some debris or something. And here you see, from beginning of time, there's always brain lesions. It starts from simple angiography, angioplasty, everything else. But obviously, it's not necessarily stroke as we discussed, but you can have various lesions on you see on DW, MRI, and you might have some cognitive decline, even in absence of any clinically defined stroke. And we know that from bypass operations from the past, and I'm sure we hear later in a surgical lecture about that. So whatever you do invasively can affect the patient brain, even sometimes can be quite subtle. We also know that there are various devices tried over decades and try to protect whichever target organ, but the results were quite problematic. So there is, so far, and it will be the end of my talk later, is actually nothing fully conclusive for this protection. It's also very difficult to study, and we are only now learning what endpoints we should use to study how effective we are using any devices or any protection strategies for those procedures. It is important because, as was mentioned, TAVI is marching unstoppably. It's becoming very soon probably most common cardiac intervention. The way it's going will overtake angioplasty over the next decade or so because of demographic and just number of patients suitable. And we know from beginning of TAVI that stroke with parabol leak are the two contentions on weakest and most significant point of adverse effect of such a procedure. This is just to demonstrate my words how TAVI is going. It's always a rosy projection for Wall Street and industry people. It's really becoming very, very common procedure in vast majority of cardiac centers. We've got a lot of devices which are, thanks to engineering, getting smaller, more forgiving for operators on a routine basis, easier to implant, reposition, etc. So technology is helping us hopefully avoid or reduce those complications. But at the same time, we are moving to lower and lower risk patients. It started from inoperable. Now we are going on to atypical anatomy, bicuspid valve, lower age, stenosis which might not be even severe, which might not be even symptomatic, or stenosis which might not be severe and is some damaged ventricle from other. These are just examples of those trials which are ongoing now for asymptomatic aortic stenosis, patients who are less than severe valve stenosis but with impaired ventricle. And we know because of stroke, there are a variety of materials. We compare to simple coronary procedure, angioplasty, we manipulate a lot of catheters in sequence. They are bigger, stiffer. Wire catheter, we might do balloon, which is quite bulky balloon. We have to position device, which can be quite challenging on the hostile environment of calcified annulus to deploy it 1, more, 2, 3 times until a good position. We might post-dilate. So there is actually a lot of punishment to find structure which contains a lot of atheroma, thrombus, etc. We also cause some hemodynamical problems. We need to stimulate the heart to deploy. So it's actually a lot potential to have a stroke or some brain damage for whatever reason. And it's quite scary when you start looking at MRI. Really, almost all patients have something on their MRIs. And we know that it's all those things, if it happen, increases risk of any further adverse events, mortality, dementia, cognitive decline, etc. And again, as Peter already shown, we are finding a lot of things. It's not necessarily emboli from bits of atheroma. The thrombus is there very often, so small bits of thrombi, small bits of myocardium, everything. But it's very common. When you start studying MRI, you see in all TAVI procedures. Size matters, as you will see later in trials as well. So it's sometimes probably worse. It goes more dispersed, small particles than one volume on one place. We know that the risk, and again, we've already seen that, is quoted as 5 risk in those pivotal initial trials, but those were very high risk elderly patient, inoperable devices were rigid, 24 French, similar sizes, and operators obviously were not that skilled with technique. But same time, from early days, because we must not forget that those patients either can't have a surgery or later they have one of those options, either surgery or TAVI. So we obviously need to be one comparator is with the surgery. Seems to be that the rates is similar, so it's definitely no worse, which was encouraging from early trials. It was a partner trial and CoreValve, US pivotal trial. Same time, we're just not eliminating as we are getting better, and devices kind of stroke is always there. And as again Peter said, that clinical one is about those 2%. This is a US National Registry at TVT registry. This is another French registry again, which look for 3,000 patients. And again, there's a stroke which analyzed come to about 4%. This is from all historical devices up to a couple of years ago. So there are since then some smaller devices which use as patient gets older, or because other valve diseases, they get more risky. We also know that happens acutely, because it makes sense it's during procedures. So within first days or couple days of procedure, and again, this is confirmed in this French study, even though the patients have a stroke later. We now learn to calculate surgical way 30 days what matters, but in practical terms, you manipulate your catheter during procedure, so we expect the majority will first couple days. As you see, it's confirmed from this national French study. This is with contemporary devices. We got now about 10 CE-mark or marketed devices, and they are similar. There's argument that one device on balloon is causing more than self-expanding, whether there are any features, but it was not tested in any prospective randomized fashion. So we just need to conclude all of them bring strokes. Doesn't get better with experience. We started doing some single cases now. Typical center does a few hundreds of such cases. Strokes are not disappearing. They are still there, and they are there in small but still substantial number. We know that once you have a stroke, your risk of mortality, again, from the randomized trial, is 3 times more than if there is on some valve going okay. And again, we alluded to at the beginning, we just have a neurologist, a simple clinical assessment. Now we are learning more and more for future trials how to assess those subclinical strokes and different stages. We've got so-called VARC, which is Vascular Aortic Research Consortium. So there's a unified definition for adverse events for TAVI procedure, which developed from clinical adverse and ARC. It was Aortic Research Consortium, so it's really to unify it. And we got consensus on that, so for all future trial studies, we have well-defined all subclinical strokes, cognitive impairment, etc. We've seen devices here, there are different ways. Either you are deflecting your debris or thrombus, or you are protecting with special filters, should not go up. Obviously, the problem with all those devices, you need to put them into body as well, so you are still performing invasive procedure into vasculature. This is some new devices which use, again, deflector. Problem deflectors, you might deflect them from cerebral circulation, but where you are going to deflect them? They go to kidney, go somewhere else. So again, we don't have a totally ingenious solution. There's still some anatomical limitations. You need this is a CE-mark device, Claret, brachiocephalic diameter, certain size, and you need certain size of common carotid just to place the device. So again, we cannot protect all patients. Here you see how we are deploying it. So again, it's a part of procedure. It often takes, with today's TAVI device, almost same time as a procedure, just take 3-4 minutes. It's deployed. So we're deploying those baskets into right-sided circulation. You are not protecting left vertebral artery. So again, you are not protecting completely. You just put those baskets to the 3 out of 4 areas you want to protect, and then you perform a procedure. But again, says to do that, you need to place the device into circulation as well. So obviously, it's another intervention. There are a lot of encouraging study from individual trials from individual centers, which were randomized protection device or without. And striking feature always was there is a lot of those MRI hits. Volume is less, number is less. Nevertheless, it still seems don't have enough information about reduction of clinical stroke or even this neurocognitive impairment. This is another study called CLEAN study, which is similar, and this Ulm is a very big center who actually pays a lot of attention to this procedure. Again, seems to be show a reduction with all those hits on MRI, and some hint there might be a reduction in clinical endpoints. But then it was followed by sobering fact of Sentinel trial, which was first randomized trial, which was comparing to historical safety arm and then comparing protection device without. And again, while we've seen reduction in those MRI hits and volume, we didn't see any difference in clinical stroke rates. So study didn't reach its endpoint. Despite that, device seems to be safe, and as such was approved by FDA and it's approved in Europe as well. So you can have it on the shelf, and that is TAVI operators differ between enthusiasts, realists, and skeptics. But bottom line is clinical was not reached. Why was not reached? One discussion, actually there was difference if they only look in the first 2 days of stroke. So interestingly, actually third day seems to be more stroke. But again, then you look into what would be logic having third day stroke entirely related to a procedure. Also, what's important, there was some problem, a stroke or complication related to device placement itself. It was very small, but nevertheless it was not zero. So we didn't see any significant reduction from the own, and that's important that it AF discussion earlier. So really until you expose it to hard data from randomized trials, you never know for sure. So far we don't have evidence from those trials. You need to do the procedure a bit longer. You are bringing a risk from vascular complication implanting second device, which is a protection device. We just need to look into whether in certain subsets or whether we define that interval when we count to prevent a risk. We just need to work hard on that. So those being safe, we just need to work whether it be different devices or different trials with different definition. Until we know that comes to individual operators. So in my hospital, we do about 300 TAVI, so it's medium-sized center. So we have it on the shelf, but when to use it, I'm not sure. So one idea would be if you see something like this, you see some mobile structures on aortic valve, you see thrombus, if ventricle, you see the valve which really doesn't look very attractive, a lot of atheroma, you see clot of left atrial appendage, maybe. At the same time, it makes point if you think that's like in car. So to be safe, you should have like seat belts usually for everyone because you never know when you need the protection. So this is hotly debated now interventional meeting. As I say, jury is out, but same time, and again, as Peter said that, we need to look into patient and see what's patient interest. And here we're learning again, consenting patient type procedure, they actually don't mind it much. Well, obviously they mind dying, but they're much more worried about having strong doing procedure. And this is even proof with this study that shows that actually staying alive, it's less in the order of importance than maintaining independence and ability to do various specific activities. So stroke is tremendously important for interventional cardiologists, especially with those more robust procedures like TAVI. We know that silent damage to brain are frequent and probably have an impact on cerebral function. While initial single center results of protection there is promising, they so far failed to be validated in powered randomized trial with defined endpoint, but it's complex to define those points, and then I think neurologists will be needed and imaging specialists more than until now. As TAVI is moving to lower risk group, then obviously we need to aspire not to have any new brain lesions and eliminate on the reduced stroke to absolute minimum or at least comparable to other intravascular procedures. Thank you very much.